Hello, friends, and welcome back to This Whole Life. It is such a blessing to be here with you, and we're so excited for you to be here with us for this great conversation with Dr. Katherine Posch. Recently, Ken had a chance to sit down with Dr. Posch, who is a licensed clinical psychologist in private practice in Minnesota with Renew Behavioral Health. Dr. Posch originally graduated from college at the University of Texas at Austin with a degree in psychology, and went on to receive her doctorate in psychology and clinical psychology from Baylor University. She has a number of areas of expertise, including anxiety disorders and depression, but in particular for our conversation here today, one of her great areas of expertise is obsessive compulsive disorder. She's going to have a great conversation with Kenneth to share with you about OCD, the ways that it presents in her clients and in individuals, and especially the hope that is offered through really great evidence-based treatments and medication. And they're also going to get into the ways that OCD touches on religious faith at times in a presentation like Scrupulosity. We're so excited for you to hear from Dr. Posch, and you can find out more about her work at renewbehavioralmn.com. And now, here's Kenna and Dr. Katherine Posch.
I just seen people get their life back in so many ways, and just from my worldview, really get to live the life that God created them for, wants them to live.
Welcome to This Whole Life, a podcast for all of us seeking sanity and sanctity, and a place to find joy and meaning through the integration of faith and mental health. I'm Kenna Millay, a licensed marriage and family therapist, and I'm happy to bring you this podcast along with my husband, Pat Millay, a Catholic speaker, musician, and leader. We invite you to our kitchen table. Okay, not literally, but you're definitely invited into the conversations that we seem to keep having once the kids have scattered off to play and we're left doing the dishes. We're excited to share this podcast for educational purposes. It's not intended as therapy or as a substitute for mental health care. So let's get talking about this whole life. I'm not gonna stand here with my friends down and out. Welcome back to This Whole Life. It is so good to be with you, listeners. Thank you so much for coming in for another episode, another valuable conversation. I have with me today Dr. Katherine Posch. Katherine, welcome.
Thanks so much for having me. So glad to be here.
Katherine, you and I have been connected through a mutual friend lately, and you spent some time with our Martin Center clinical team earlier this week even. So I'm just feeling really spoiled right now, getting to just sit at your feet and receive the wisdom that you've got for us. And for our listeners, you guys, this is going to be an awesome conversation. There was so much already off of the pre-interview discussion that I'm like, oh my gosh, we just need to get going and recording. So I'm excited to talk today about OCD and specifically, Katherine, the insight you have for us around religious scrupulosity and the ways that we can be living a more free and full life. But before we get there, I'm getting ahead of myself as always. But I want to check in with you. We have this tradition on the pod of asking our guests to share their high and hard. So would you be willing to tell us a bit about life lately for you?
Absolutely. So I guess I'll start with high.
Yeah.
Hi, I feel so Minnesotan talking about the weather, but just this weather recently, the sunshine, the warmer temps, especially after the cold, dreary days that we were having, have made such a difference in my mood. And I'm sure you can relate, but it just surprises me every time it's that way.
Yeah. How many years have you been here in Minnesota now?
I've been here since 2020.
Okay.
So not too many years.
And was it Texas primarily all before that?
Texas and then Salt Lake for a year.
Okay.
So Texas my whole life.
Okay.
Salt Lake for a year. And then, I moved to Minnesota.
So we're two Minnesota transplants.
Yeah.
Florida, Texas, but we're here for it.
There's some differences for sure, right? From the north and the south, but it's good to be here.
Good. I'm glad November is treating you well.
Yes.
And maybe a hard lately.
Yeah. So to be honest, I have a newborn son, and hard has just been the whole sleep thing. I'm sure any new parent can relate. Just, you don't really realize how much of a need sleep is until you have a baby. So, and just navigating all of that and the whole sleep training thing and what to do or what not to do. There's just so much information. And I would say that's my heart of this week is just lots of sleepless nights, but it's all okay.
Well, and what I remember, we're a few years removed now from the newborn stage, but there's still, I don't know if anyone's told you yet, but there's still some sleep stuff to come in the years ahead. But I remember it's just like the multitude of voices that have opinions, right? And sometimes we seek those out. All the Google searching I did at like 3:00 in the morning, like, what is the matter with my child? Or like, how to fix this. And then the books, but just, the empirical wisdom that people want to offer because they don't like to see us suffering, or they found the magic bullet that like worked for their kid and they want to share it. But it's a lot to sift through.
Oh yeah. Yeah. Especially as someone who just wants to do, I'm someone who wants to do the right thing. Yeah. And I feel like everyone's saying that this is the right thing to do, but it's completely different. So it's hard to navigate or, do what's best for you and your family. But it's like, I don't really know what that is yet.
Right.
So
right.
A lot of trial and error and yeah, definitely relate to what you just shared.
Yeah. Yeah. Well, thank you for sharing that. And I can certainly relate. Yeah, to sleep. We've talked about that a lot here on the pod, actually. We should actually probably do an episode on sleep.
Right.
Although, again, there's just so many opinions, right? Like, could we find just one person to speak on that? So, I would say my hard lately has been just a new wave of grief that's coming with just, some deaths in our family over these, recent years. And I don't know. I think maybe within that hard, this expectation that a different year, another year will make things easier. And certainly for sure, right? There's maybe a little less rawness. And also, I think I'm taken aback sometimes by how fresh it can all feel. And so thankfully, have enlisted the help of a new therapist. The therapist I'd been seeing through a lot of the grief had to take a leave of absence, but have been connected with someone. So the hard is just that starting up again and being honest about, another season, what feels like another trip around the spiral staircase of grief, and just the energy that I'm aware that takes and how I need life to slow down a little bit so that I can process that and be attentive to it in a healthy way, in a healthier way. So that's definitely a hard. I would say the high is that both, I would say, in my office with clients and also with my children and with people I love in my personal life, just seeing some change and some growth for some folks that is just, it's so beautiful to sit back and watch. And I say sit back on purpose because if you listen to this podcast ever, you know that my tendency is to overfunction and my tendency is to try to be in control. And so really lately witnessing the fruits of times when I haven't, and when I see our kids sort something out, or I see a child kind of come to a new level of skill in a particular area that I've had my eye on, but have tried to keep my mouth, shut, or certainly with clients, like them having these insights and these breakthroughs. I want to believe it's, because of my accompaniment with them, but I also know like, it's just God, like moving in their life and in their world. And so it's, such a privileged place to be. And I imagine, Katherine, you can relate to that as a clinician too, but, people say that, man, this must be such a hard job to be a therapist. And I'm like, oh, it's so rewarding.
It is. Yeah, it is hard to sit with people when they're in pain or suffering, but to get to it's such a privilege to be able to be with people and then to get to see the healing that's on the other side of that. It is so incredibly rewarding.
Yeah.
And I relate to what you just shared. Like, there are many times where a client will refer to something that I said, not even really thinking about it, right? And that was something that really made a difference for them. Or many moments where I'm like, I just kind of need to get out of the way. Let this person use this time and space and in the way that they need to, versus kind of how I feel like what I'm thinking or planning, or it's such a it's like, it's humbling in a way, right?
Very, very much so. Very, very much so. Yeah. So that's kind of me lately. So maybe actually, Katherine, this is a good moment of transition to just let you share a bit about how you got into this work. And there's so many things in the world of psychology and psychotherapy that we could do and focus on. And you have really found this passion for working with people suffering. And I use that word intentionally, suffering with OCD. And so, what drew you to it, and what makes it so meaningful for you?
When I was in my graduate training program, I had an opportunity to work in an anxiety disorders research lab. So I had the opportunity to have a lot of experience with people that were dealing with a wide variety of anxiety disorders and issues related to anxiety, like social anxiety or fears of things. And so within that, I had some experience working with people that were struggling with OCD, but not a lot. It was actually not until I got around the time I got licensed that I decided to do a deeper dive into training and really just have fallen in love with the work. And I love it for a couple of reasons. The first is I really enjoy working with the people that I get to work with. I don't know why, but I have noticed that OCD tends to afflict some of the most kind, caring, conscientious, gentle-hearted, awesome people. And that's not to say that my other clients don't have those qualities or don't have wonderful qualities as well. It's just, I don't know if you've noticed that pattern, but it's just,
it's almost out of such a deep care and a desire to be good and to be good to others, that the disorder like develops.
Right. Yeah. Yeah. And causes so much suffering for people. And another reason why I love working with OCD is that it's never the same. It looks so different. I could meet with 10 clients with the same subtype of OCD or presentation of OCD, and it would look totally different. So it requires a lot of creativity and thinking and collaboration with the client to really get them on the right track for their treatment. And I enjoy that. And then I think the last reason that comes to mind for why I enjoy it so much is that we have treatments that work really, really well. And I think people don't know that. So the evidence-based treatments that we have are effective and so helpful for people, and getting to see people's lives open up again after struggling, usually suffering in silence for many, many years. Is it's just a gift to be able to be a part of that.
Yeah. You get to be this beacon of hope maybe in their life when they've maybe lost hope and given up that they can be any different.
Yeah. I really appreciate the hope that the treatment offers. It's a lot of work on the part of the client. It's inspiring to me, the courage and bravery that it requires and that it takes for somebody to make that leap of faith and work on approaching these difficulties in a totally different way that feels really scary at first. And it's inspiring to me because I just think that, we're wired to avoid things that are scary, things that are painful. And that is actually a really good thing, right?
Survival.
That's a gift. Yes. People that don't have that don't, it's an issue, right? So you're kind of having to go learn the value of sometimes going against that wiring, that natural, that instinct that we have, right? To avoid pain, avoid things that are difficult, avoid suffering, which is not, again, hear me say, it's not a bad thing across the board. It's just that when we begin to operate out of a place of fear and anxiety, it can become so costly.
Well, and I think about that not just for people diagnosed with clinical OCD, but for all of us. I mean, that place of fear, I often use the term with my clients, like, I don't want your world to be so small. I don't want you to have to be cowering in a corner without a lot of options. I mean, we weren't made for that. So I guess as we're getting into this, Katherine, I wonder if you could just help us understand, what is OCD? I mean, particularly in social media and, it's thrown out there. Yes. And what are we actually talking about when we speak of it in this clinical context?
Yes. I love that you just phrased the question in that way, because I want to start off by saying what OCD is not, right? And it's referring to exactly what you just said. So there's this phrase I feel like that gets thrown around in social media or elsewhere, like, that's so OCD, or I'm so OCD. And it's a tongue-in-cheek thing. I know people don't mean any harm by it, but it's problematic for a couple of reasons. I think that it sends this message that what OCD is, being especially neat or clean or avoiding germs, washing your hands a lot. Those features can be present in some OCD presentations or cases, but I would say that the vast majority of clients that I work with don't have any of those, don't do any of those things. Yeah. And it's a problem because it leads to a lot of a misconception about what OCD is. And so people that have the condition don't even know that they have it.
Yes, I find that as well. They are shocked that this is what this is. Yep. Because it doesn't look like hand washing.
Exactly.
Or doorknob turning or, yep.
Exactly. And then I think that the last reason, or another reason why I'm not crazy about it, is it implies choice. Like somebody is like choosing to order or do these things, or like they like to. And people don't choose to have OCD.
Yeah.
And when somebody is in the throes of the disorder, when it's untreated, they really don't feel like they have a choice in doing behaviors like that, which I can get into. But so that's what OCD is not. So then what is OCD, right? So OCD is a mental health condition that affects about 1% to 2% of the U.S. population, which sounds small, but that's 2 to 3 million people. It's a lot. Yeah, it's a lot of people.
Wow. I did not think of it in those terms. Yeah.
Yeah. And I say that because the condition can make somebody feel like they are the only one and they are so alone. And they're not.
Yeah.
And it's characterized by two main symptoms: obsessions and compulsions. So the O and the C of OCD. Obsessions are unwanted, intrusive, usually thoughts or images that come into a person's mind. And these are thoughts and images that are really typically very against the person's values, sense of self. They can be really distressing, very disturbing, shocking in
Which
nature.
is why it's upsetting, right? Because it's not consistent with who they want to be, who they see themselves to be.
Exactly.
It goes so counter to who they feel called to be.
Yes.
Yeah.
Exactly. Which is why I almost don't like the term obsession to describe it. Because when we talk about obsession in everyday
it's willful.
Terms, it's like, I can't get enough of it, right?
Yeah, I'm obsessed with a new pumpkin spice latte.
Yes. I ordered it 4 times.
Yes.
And it's like, that could not be farther from the truth for somebody with OCD experiencing obsessions. They're popping into their awareness with, it feels totally out of their control. It's really disturbing, very upsetting. Because of that reaction, the person feels compelled to engage in what are called compulsions. So these are just behaviors or even mental behaviors that somebody does to get rid of or sort of like cancel out.
Like get relief?
Yes, get relief from the unwanted thought or image that just popped into their mind.
Okay.
So Common behaviors could be, checking or asking for reassurance, or confessing, or as in like telling somebody else about the thought. It could be repeating things, or it can be things that somebody does in their mind. So praying, or even counting to a certain number, or replacing an image with a different image. It looks a lot of different ways. It's just this, I think what's most important in explaining it is it's the obsession is occurring, the intrusion, the unwanted thought image is coming in. It's causing a spike in anxiety. And so the person feels like they have to do something about it to get rid of it.
Like, let's push this away.
Exactly. And it leads to a temporary relief, but inevitably the intrusive thought or image comes back, and usually even stronger, and oftentimes more upsetting, more disturbing. And so the person engages in more behaviors. So the behaviors become repetitive and oftentimes more elaborate, and it can become very time consuming and really take away somebody's mental energy and become very impairing and interfering in their life.
Well, and I'm thinking about, having been with clients whose loved one has OCD and the mounting frustration because of how much more elaborate their compulsions become, and they're like, it's taking over my life. And I think especially, Katherine, as you're helping us understand this intrusion, I do not will it any more than I will a robber to walk through my front door and steal my silver, so it's hard for the loved one because it looks like you have choice, you make choices all day long, and somehow you continue to choose, and we are late all the time to all these things. And that frustration.
Yeah. And I think I'm so glad that you said that or brought that up. I think another thing that really can be confusing or frustrating for a loved one is the fact that OCD doesn't respond to logic or reason. So, and if the clients that I work with that have OCD are very bright.
Yes,
like it's not a problem of understanding or not having the right information or education. It's a mental health condition. And so I think people can say, well, that's unreasonable, right? That you're needing to do that over and over again. You already did it. Or that's not a reasonable way to respond, right?
Yeah.
And it's that when you have OCD, it doesn't feel like you have a choice. And it doesn't make sense, but you don't feel like it's very frightening to think about not doing the compulsions. So for the sake of example, I'll share a common one that comes up with a subtype of OCD, responsibility OCD. So let's say that you're cooking in the kitchen and you need to go pick your kids up from soccer practice, and you leave the house and you have the thought, did I turn the stove off? Right? And in your mind that you turn the stove off, but it causes this spike in anxiety, right? And you can maybe walk through the steps in your mind and get reassurance like, yeah, I did do that, right? Well, in the mind of someone with OCD, they have that thought, did I turn the stove off? What if I left it on, right? And there's that spike in anxiety, and they might engage in a checking behavior. So they might go back to check that the stove is off, right? They might get back in their car and keep driving. But then the thought comes again, did I really turn the stove off? What if I bump one of the knobs? I didn't realize it. Can I really be sure? Did I really, reviewing in the mind, did I really see the stove off? Am I absolutely sure? And the anxiety builds and builds and builds. And they go back and they check again. And then they leave and they have another thought that is associated with a lot of anxiety and distress, where they engage in another behavior. And you can see it's a very simplified version of what can happen, but you can see how time consuming this can become for somebody.
Absolutely.
Yeah. And I don't want to, again, this comes in so many different forms, but I'm just trying to illustrate kind of like that process of never being able to really get certainty around something, and just that agonizing cycle of having to do things over and over again, prompted by these really distressing, unwanted thoughts or images.
That lack of peace.
Yeah. And just the spiral that people get caught in.
I mean, I guess, first of all, you talk about the cycle and how it intensifies and it seems to grow. The compulsions being more elaborate, the fear, the obsession, the intrusive thought, and the distress that it causes, that gets bigger, feels more costly to them. And I remember when you were with our clinical team, you named it as this vicious cycle, and talking about kind of OCD is this like self-propelled machine that could go on into perpetuity if we let it. And so, I'm thinking about how much clients that I have walked with this disorder, how much they want out. So when you talk about like, it's not a lack of reason, it's like they also know that this isn't the way that they want to live. So I'm wondering about, you mentioned earlier that there is hope, right? That there is, particularly through some of these evidence-based treatments that you use. And so I'm wondering if you can describe a little bit about what you have found is helpful and why you think it is like this unreasonable, machine that is OCD. Like, why does it respond to these best practices that you have come upon in your work and in your research?
So the best evidence-based treatment that we have for OCD, the frontline treatment for OCD, is a form of cognitive behavioral therapy called exposure and response prevention. And it's really important that someone receives exposure and response prevention and not just general CBT, because exposure and response prevention is specifically developed for OCD.
So exposure and response prevention therapy, or ERP, that's under this big umbrella of CBT, of cognitive behavioral therapy, which most of us have heard about. And again, it's just so out there in the culture and in the media.
Yes.
So it's a piece within that, but you're saying that ERP specifically has been developed to get at the unique kind of traits and this ongoing vicious cycle that is OCD.
Yes. And to illustrate how it works.
Well, and I'm wondering in particular, could you, because I know in our clinic, we see a lot of OCD, particularly related to religious scrupulosity. And it's just so tricky because there are these very beautiful acts of faith, right? These rituals that we as Catholics, we as Christians participate in, and then they somehow get distorted or askew. And so that feels, it's just this kind of ball of knots of like, how do we untangle this without inadvertently discouraging someone from a objectively beautiful religious practice? So maybe if you could illustrate with us with that. I'm throwing a real curveball at you.
Yes, no, I'm happy to do that. So, okay, so I think I'm going to start with an experiential exercise, if you're open to it.
Yeah, let's do it.
To illustrate how OCD works and then how the treatment works. And then I'll go into how do we apply this to scrupulosity or religious forms of OCD.
Beautiful.
Sound good?
Yeah. Okay. More than I hoped for.
This is like long-winded, and anyways, it's kind of how
that's
I
what
roll.
We're here
but
for.
That's okay.
Yeah.
Okay. So I want you to bring to mind the image of a pink elephant.
Okay.
Got it?
Got it.
Okay. And can you tell me a little bit about the elephant that came to your mind? Like, is it a cartoon?
It's a cartoon. It has tusks and it has a little bit of hair. I'm realizing it might be a woolly mammoth, actually. But can it count as my pink elephant?
Of course.
It's very pink.
This is your elephant.
It is bordering on magenta. And it's outlined in black like a cartoon.
Okay. So have that image in your mind.
Okay.
Right? And now what I want you to do is I want you to push that image out of your mind.
Okay.
Okay. And you can think about anything else, any other, but just don't allow that to come back to your mind or any thoughts related to it.
Okay.
And if you notice it, then really get rid of it quick, because it could mean something about you, or it can mean something about your future, or things can go really, really bad if you let it. Just trust me. Just make sure that it doesn't come into your awareness, your consciousness. Think of anything else, okay?
Okay.
And I want you to do whatever you have to do to get rid of it.
Okay. Working really hard over here. I think that's the point, but I just wanted you to know.
What do you notice as you try to do that?
Yeah. Well, at first I was like, oh, I'll focus on my imaginary garden that I would love to plant someday. And then the more you were talking, I was like, focus harder. Just focus on one plant. Just focus on one leaf. My gosh, just like anything. And yeah, that elephant just kept creeping. My woolly mammoth just kept creeping back in.
There they are again.
Yeah,
right?
Totally.
Yeah. So that's a phenomenon called thought suppression, which is a human experience that happens for all of us. The harder that we try to push away thoughts or images, the stronger and more frequent. The stronger they come back, the more frequently they come back. So let's just, for the sake of example, like take it back to that OCD cycle, right? So the elephant represents that unwanted thought. And I just had you pull something neutral to mind. Imagine that this was something that felt like it compromised whatever is most important to you in your life, right? Someone's alarm system goes off. And so then they engage in all these behaviors to get rid of it. And the reasons why vary. Sometimes it's like just the presence of it is so unsettling, they want to get rid of it. Sometimes there's fears of, if this stays around long enough, maybe something bad will happen, or I could act in that way, or, or it could just be, I just need certainty around this. I just need this to go away and be resolved. But all that frenzy and all that activity is actually all those things that a person is doing to feel better and to fix the problem is actually perpetuating the problem and making it worse and worse.
And all the things are so natural, right? Like to take our mind off of it, to say, no, I don't want that. I mean, it's just so natural. And you're right. Like the harder I push, the more it intrudes, back to that term, and invades my mind. Yeah.
So exposure and response prevention, what it does is it helps people to actually approach those intrusive, unwanted thoughts or images, and allow the anxiety to go up, to rise without performing any of those behaviors. And what that does is it breaks that cycle, right? So it's not getting reinforced.
Because there's kind of 4 legs to this cycle table. So there's the obsessive thought, that intrusive thought.
Yes.
Then there's the distress, the anxiety that shows up. That's number 2. And then there's the compulsive behavior or action or mental action. And then there's that temporary relief. And then you swing from that step 4 back up to the top to number 1. And so you're saying take out leg 3, that compulsion, and short circuit it. In the hopes that it moves in a new direction.
Yeah.
Okay.
And so eventually people will feel the anxiety, but over time that anxiety goes down.
Okay.
And so it gives basically the brain's alarm system a chance to like recalibrate.
Yeah.
And realize, okay, because all of those behaviors that you're doing to get rid of it are telling the brain, this is important, this matters, this is meaningful, right?
So inadvertently reinforcing that message.
Yeah.
Like on the one hand, I'm like, I don't want to think about this thing. But then the way I'm reacting is actually telling my brain, my nervous system, something big is happening here and we must pay attention.
Exactly.
Got to make big meaning out of this.
Yeah.
So, yeah.
Yeah. And it's not intuitive because of that temporary relief that happens when somebody does do the behaviors. that's saying, oh, this is a good way to deal with this. I can get rid of it in this way. And they can temporarily, but it never is enough. That's part of it being so torturous. It's just, it's never quite enough.
Yeah. I'm also wondering about medication.
Yeah. I'm glad you asked. Fortunately, there are medications that work really well for helping people who are struggling with OCD. So, specifically, high doses of a medication called an SSRI, but it's a standard medication that's prescribed for a wide variety of anxiety and depressive disorders.
Okay.
But the dosage is different typically in people with OCD. So it's important that you work with a provider who's aware of that or educated on that diagnosis. But that I've seen it be really, really helpful for people and a really useful tool that's often used alongside therapy. So that is something to absolutely look into as well.
Yeah, love that. A 1-2 punch. You know, both the talk therapy, the behavioral change, and also the medication support so that those therapeutic tools can be helpful. Sometimes we're so far in the hole.
Yes.
It's hard to be able to use what we're learning in therapy.
Yeah, I've seen it be really, really an important part of treatment in some cases for just, quieting down the intrusions just enough to where somebody's able to really engage in the treatment, and lowering that anxiety just a little can make a huge difference. So I'm glad you asked.
So can you, kind of going back to when we were talking about some of the features of OCD, I imagine there are people out here. I remember being in grad school and being in my psychopathology class where we were discussing, the various disorders, and our professor warning us, like, you're going to go home every day thinking that you have a different disorder, because there are ways in which we can all relate to elements of this. But in particular, I'm thinking about onset. So ages when this is really maybe going to make its first appearance, or a very strong appearance. As I know we have a lot of parents who listen, and I've got kids. I know what it's like for them to have that particular sock, pair of socks, or that one blankie, or what have you. And so our minds, out of love, can go to that place of like, oh my gosh, is this what I'm seeing? So just, maybe share a little bit more about that.
So, common ages of onset, there's two. The first is in adolescence, so that 8 to 12 range, and then the second that we see is in late teens, early adulthood. That's not to say that OCD can't have an onset at a different time. It can also onset after a major change or stressor. There's a specific form of OCD called perinatal OCD, and that onsets after sometimes before the birth of a child or after. So those are common ages of onset that the research shows and that I see in my own practice.
And maybe actually while we're discussing this, Katherine, if someone is concerned about themselves or about someone else, who is best to help them in terms of a diagnosis, in terms of sorting out what might be generalized anxiety, what might just be a preference, or actual OCD?
Yeah. So the best thing to do would be to talk with a trained mental health provider. So somebody who's trained in exposure and response prevention or experience with treating OCD. And those providers can be found through the IOCDF.org website. That stands for the International OCD Foundation.
Okay.
And on that website, there's a directory of therapists.
Oh, amazing.
Yeah. In your area, you can search by your zip code. And there's also a lot more information provided there that I wish we could cover completely in this podcast. And
we can link up that website so that folks listening who do want to maybe get some questions answered, things clarified, can speak to someone who is empowered, in a place of power, to help.
Yes.
Okay, so that is super helpful. Listeners, I'm happy to be the guinea pig over here to illustrate these points. So taking all of that, Katherine, and applying it to OCD that shows up around faith and religion.
Right. Yeah. So OCD can take, the obsessions can fall into several different themes. they could be things related to contamination or cleanliness, which I think is where that so OCD comes from. Could also be themes that feel more scary or taboo, like violence against self or family members or others, or themes that are related to sex or sexuality that are really unwanted and disturbing for the person. That's just to name a few. One theme that shows up is religious or moral OCD. And so this is when the OCD latches on to religious content that's important to a person. So usually there's excessive concern around violating some part of moral doctrine, or committing sin or blasphemy, or another common one would be like fears around being possessed or becoming possessed. That's something that I see a lot of. So the OCD really centers on and fixates on those things. And then the person who's experiencing intrusions related to that, and that spike in anxiety, can engage in religious practices to find comfort or reassurance. So I guess, to take examples from Catholicism, right? Confession or, going
to mass, saying the rosary.
Yes. Prayers.
Absolutely. Just a lot of outward signs that we can make of an act of faith.
Yes.
Yeah.
Which are not problematic in and of themselves, but when it's an OCD issue, a mental health issue, and it's not a faith or religiosity issue, those rituals, they never really bring peace. They someone goes to confession, but it feels like they just didn't confess quite enough, or somebody prays and they become concerned that they maybe didn't pray in just the right way, or they do all those things and then the intrusion happens again and they feel the need to repeat those things over and over and over and over again. And it leads to this cycle of guilt and shame and exhaustion that the person really can't find peace.
Yeah.
Is that illustrating what that might look like for somebody?
Yeah. I think that phrase, doesn't bring peace, that feels like a hallmark of OCD versus, some people do have maybe more stringent religious expectations, like certain communities or around fasting or around times of prayer. And so I think that peace, PEACE peace, that seems like the distinguishing factor between when is this like willful and I am empowered in my life to make these choices as an act of faith or an act of atonement or sacrifice, and when is it not a compulsion? Like when is it not feeling like it's my willful choice anymore? That sense of peace seems like a good litmus test. Yeah.
And something that I want to just throw out there is that with the treatment, with the exposure and response prevention, a common concern is like, well, is the provider going to ask me to stop practicing my faith, or are they going to encourage me to do something that's against my faith or not in line with my faith values? And I just want listeners to know that with a well-trained provider, certainly not. My goal is to get people to be able to practice their faith in a way that I use the percentage 80% of people practice in their faith community. And it's not that I would encourage someone, if confession or prayer or things like that are an important part of their life, I wouldn't ask somebody to stop doing those things, right? But I would work with them to tease apart, okay, what part of this is OCD and what part of this is practicing your faith, and discontinuing the part where OCD is getting caught, and practicing those important religious rituals in a way that is healthy and life-giving and not feeding the disorder if they do have OCD.
Yeah, which sounds really tricky. I mean,
is.
that sounds like really difficult work.
Yes, it is. And I think it's part of that collaborative process that I enjoy so much. Like you're working hand in hand with the therapist to plan this out and decide what feels comfortable. Oftentimes, religious mentors or leaders are pulled in, and so it's a very thoughtful, intentional process that you go at it a very gradual way with confronting these fears. I want to make sure I put that out there too.
Yeah. No, I also remember you talking about that with our team this week about, talking about hierarchy.
Mm-hmm.
And so starting with those less distressing exposures, that's part of the protocol of the treatment, that we're not going to go for the jugular at the beginning. I know people who have feared engaging in ERP therapy because they're like, they're going to throw the biggest, challenge at me. And so it was really reassuring to hear you say that of like, no, we want to, I think of it as like stretch that window of tolerance without overwhelming you so much we throw you out of it.
Yes. Yeah. I always say my goal is to challenge you, not to overwhelm you.
Mm-hmm. Yeah.
We decide what's going to feel challenging. And ultimately it's important to address, all parts of what's all the components of OCD that are assessed for and decided on by meeting with the provider. But, it's at your own pace, and it's really, really effective. It's really, really effective. I just seen people get their life back in so many ways. And, just from my worldview, really get to live, the life that God wants them to created them for, wants them to live.
Yeah,
so
absolutely. Yeah. Oh, I love that. So, okay. So I'm hopeful, listeners, that you are feeling filled with hope if this message has pertained to you, and maybe you are recognizing that there's, maybe you already have a formal diagnosis or have wondered, and maybe are living in silence, in the shadows, in suffering. So I'm hopeful that what you're hearing from Katherine is giving you a new sense of, reason to hope. I also, Katherine, want to speak to those who may be listening who are loved ones of someone suffering with OCD. Again, whether it's formally diagnosed and that person is maybe seeking treatment, or they suspect, right? And they're feeling the intrusion themselves of OCD in that relationship or in the family life. And I wonder if you can say a bit about how could people like that be supportive of loved ones? And something that you said in our training earlier this week that really struck me is how often we as clinicians, and I imagine folks as family members and friends, could unknowingly be perpetuating or contributing to the vicious cycle. Can you talk to us about those?
Absolutely. Yeah. So I think that the best place to start, if you're a loved one of someone that has OCD or that you think may have OCD, is to get educated yourself. I think it can be confusing to loved ones why someone is struggling in the way that they're struggling.
Because if that's not how your brain operates, you really just can't imagine how that goes.
Right. It's not responding to like logic or reason or other ways that you would help solve things. Right. And so I think getting educated on OCD and that IOCDF, that website is a great place to start. They have a lot of resources for people. I think also, Kenna, you just touched on this, but oftentimes families, loved ones can get pulled into a person's compulsions, whether, commonly I hear people asking for reassurance from loved ones or...
So that's like we're driving away to church and a husband turns to his wife and says, did you turn off the coffee pot, or did I turn off the coffee pot? And
yes,
that kind of reassurance seeking.
Yes.
Okay.
Yeah. That's repetitive and doesn't respond to. I'm like, I probably have said that to my spouse many times. Sorry,
but it's repetitive. I don't have peace. I don't actually believe that.
It's like, I can't even trust my senses anymore. Right. Yeah. So, being mindful of that, or, oftentimes people with OCD that are in the process that when it's untreated or it's in the process of being treated will want to avoid triggers, things that could trigger the intrusions. And so really encouraging their loved one to approach rather than avoid things in a way that is gentle.
Yeah.
And I think that this is where a treatment provider is really, really helpful. I think it's important that families and loved ones are involved in treatment, especially if they're getting pulled into compulsions, because it can be really, really hard, if you see your loved one suffering, to not want to just give them what they're asking for. So to meet with a provider and be in agreement on, okay, we know that these things, while they make you feel better in the moment, are unhelpful and perpetuating this. So this is the way that your loved one is going to respond when they ask you for reassurance, or,
So really letting the provider kind of mediate those choices and determine like what would be the next appropriate step.
Yeah.
And how can your loved one be supportive of that?
Yeah.
And not inadvertently maybe reinforcing the cycle.
Yeah. You can always validate the distress. This is so hard, and I'm so proud of you for working on this. And it's so difficult for me to not do this, but we know that this isn't what's going to be ultimately helpful. So is there something else we can do?
So if I'm not going to, like, I answered you once about the coffee pot, and I'm not going to answer again. I'm not going to reassure you again, but I can still empathize with, like, I can see this is hard. I can see you're working hard at this. It's hard for me to not, give you the reassurance that you're looking for.
You can do this.
Yeah. Which is a fine line.
Oh, it is.
And I can't imagine.
Oh my gosh. And it's so easier. It's so much easier said than done. And I don't want to simplify it or, minimize how challenging that can be. So, with that in mind, a couple of other things that I think can be helpful for loved ones is there's actually quite a few support groups for loved ones that have, or people that have a loved one with OCD. And I think that those can be really helpful for people.
Would that also be through the IOCDF website?
That's
so we can link that.
Start.
Okay.
Yeah.
So get more information on a support group.
Yeah.
So as we're kind of rounding the bend here, Katherine, to the end of this episode, some things that are standing out to me are that have been really helpful and have maybe helped to dismantle the ideas I had of OCD in my mind, is this idea of it's unwanted. And that helps me to grow in great empathy for people who struggle with this. And I don't know, just I know for myself, when I'm in relationship with folks who have had OCD, I can sometimes get impatient. And I imagine they feel impatient with themselves. And so, I've appreciated what you've shared, particularly so that I can renew that desire to be with them in it and to be thoughtful about how I could support people like that in my life. So challenge by choice, what have you got for us, for all of us?
So my challenge by choice is inspired by a quote from one of my favorite OCD advocates. Her name is Kimberly Quilleen. I don't know if I'm even saying her name right. She's Australian.
Okay. Ooh, good accent to listen to.
She's very fun to listen to. Yes. And she always says,
what is the name of her podcast?
Oh gosh. we'll
link it up in the show
now,
notes.
my sleep deprived brain.
No worries. Pop quiz. We'll put it in the show notes, guys. No worries.
She's awesome. She's a great website, actually, blog, that I highly recommend people look at if they're interested in learning more about OCD in addition to that other one. So that maybe is a link you could throw in there. But she has a quote, it's a good day to do hard things. And she says it in an Australian accent, which I'm not going to attempt.
Your Texan, your native Texan voice can't give it to us.
Right. That's sufficient, I guess. I think that in having the opportunity to work with people that struggle with OCD, I am just continually inspired by their courage and just how hard it is to face these things that are so scary. And the freedom and life that's available on the other side of that. I think that in my own life, there have been times where I have operated out of a place of fear or shame, and it really took from the joy in my life and the growth that was available to me in my life at that time. And it is natural to want to avoid pain and suffering. That's hardwired into us, like we were talking about earlier. But when we're living in fear and it's keeping us from the things that are important to us, I think that offers a really unique opportunity to make space for that and push through that so that we can live in line and so that we can live a life that's driven by our values rather than a life that's determined by our fears.
Yeah.
And that is so difficult to do. And that is something that I get to see people do day in and day out in treatment. And it's just so inspiring to me and holds me accountable to do the same in my own life, honestly, you know? My challenge to listeners is to reflect on, whether you have OCD or not. Is there an area of my life where I am living out of a place of fear that is keeping me from living that life that is driven by my values? And can I take one small step, maybe even approaching that thing that scares me in the service of living that values-driven life?
I love that. So this challenge by choice for all of us, whether or not we have an OCD diagnosis, like this acknowledgement that all of us can get into these patterns and rhythms of avoiding hard things, and that we're going to embrace it. We're going to lean in, as we say, and learn that there is, number one, that we can get through it, and number two, that there is something of immeasurable worth on the other side. I love that. I've got like 3 things in my mind that I can think of because I'm totally up for it, and I'm absolutely pitching this to Pat too. So thank you so much. Katherine, I'm wondering if people want to be connected to you, and for those who are here, particularly in Minnesota and in the Twin Cities, who may want to connect with you professionally, how can they do that?
Yeah. So I just actually opened my own private practice.
Woo woo.
Very exciting. But you can find out more at renewbehavioralmn.com.
As in Minnesota.
Yes.
Okay. renewbehavioralmn.minnesota.com. And again, we'll link that up in the show notes. So folks, you can connect with Katherine, checking out those show notes for these resources as well. This is a a unique episode. I don't know that we've actually done any quite like this before. But again, we just know, like you said, 2 to 3 million Americans are suffering under OCD. And so we just knew this needed to be an entire episode. And most of all, to hear your message of hope as a clinician, as a practitioner. That's what excites me, is to bring that to our listeners. So thank you so much. Can we close in prayer? And let's do that. And then we'll send everyone on their way. In the name of the Father, and the Son, and the Holy Spirit. Amen. God of life, you desire to give us abundant life, to give it to us to the fullest. And we know that for so many different factors and reasons, sometimes there are obstacles to that. And so we pray in this moment that you might shine light on any darkness that is overtaken parts of our life, parts of our mind, our time, our freedom, our energy, that you might reclaim that and give us the grace to take one step toward a life of authenticity, toward freedom, toward trusting in your providence, Lord. I give you thanks for Katherine, for the time she has spent with us, and for the ways that her work is for our benefit. Lord God, we offer this prayer in your Son's holy and powerful name. Amen. In the name of the Father, and the Son, and the Holy Spirit. Amen. Again, Katherine, just cannot say what a gift it is to be connected to you. Love to have you as a colleague. Love that we are developing, dare I say, a friendship, and look forward to benefiting more from what you're learning, and hope we can offer something to you too here at the Martin Center. So listeners, another awesome conversation in the books. Feel free to let us know, how is this applicable? What are those places of growth and discomfort that you are finding yourself leaning into? Thanks to Katherine's challenge. Connect with us on the social media, Instagram and Facebook at This Whole Life Podcast, and certainly through our website, thiswholelifepodcast.com. And until next time, God bless you.
You're not alone. You're not alone.
This Whole Life is a production of the Martin Center for Integration. Visit us online at thiswholelifepodcast.com.
So exposure and Provence.
Provence.
If only we could be there filming this podcast.
Right?